In CVD-REAL-1, which was a large pharmacoepidemiologic study examining the outcomes associated with SGLT-2 inhibitor initiation versus studying other glucose-lowering agents, we showed better cardiovascular outcomes in a very large population of patients from real-world clinical practice. And so that data was very reassuring and certainly helpful from a clinical practice standpoint. But that study only evaluated patients in the United States and Europe. And it also focused on very specific cardiovascular outcomes, which is all-cause mortality and heart failure hospitalization. And we know actually that majority of patients with type 2 diabetes live outside of the United States and Europe. In fact, majority of people with type 2 diabetes reside in Asia Pacific region and the Middle East. And comparative effectiveness studies for any type 2 diabetes agents really have been lacking in that region of the world. And so the kind of main objectives that we had was to examine the broad range of cardiovascular outcomes associated with the initiation of SGLT-2 inhibitors versus other glucose-lowering agents in a kind of a more diverse population of patients from other parts of the world. So in CVD-REAL-2, we looked at patients predominantly in Asia Pacific. Majority of the patients CVD-REAL-2 were actually in South Korea, Japan, and Singapore, as well as other countries in Asia Pacific region, Australia, and then Middle East and Israel, and North America and Canada. So much more of a diverse population of patients in countries that weren't previously examined, and again, very heavy representation by Asia Pacific. And we also examined a broader range of outcomes. And these included, in addition to heart failure and death, also myocardial infarction and stroke, more atherothrombotic endpoints, which are, of course, also important to look at in this vulnerable patient population. And there is actually, aside from the fact that majority of people with diabetes live in Asia Pacific, there are other reasons to look at that population too. The treatment patterns are different, patient characteristics and risk factors are different, and even cardiovascular outcomes are somewhat different. So stroke, for example, which is of course very important, in particular for this class, given some of the early concerns that were raised about stroke risk, is one of the most common outcomes in Asia Pacific, much more common in that region of the world than in US and Europe. So there were lots of reasons for us to do that, but those were the two key differences, different countries, different world regions, very different types of patients, and also a broader range of cardiovascular outcomes. So what we did in CVD-REAL-2 was to examine data from well-established sources in 6 countries. And these, as I mentioned before, included South Korea, Japan, Singapore, in Asia region, Australia in Asia Pacific, and also Israel in the Middle East, and Canada in North America. And these data sources included national registries. It also included medical insurance claims, as well as electronic medical records. And what we did was to look at episodes of initiating either SGLT-2 inhibitors or other glucose-lowering drugs. And we, of course, wanted to do it in people with type 2 diabetes that had at least 1 year worth of data. And we excluded patients with type 1 diabetes and gestational diabetes, appropriately so. After we applied this criteria, we ended up with about 4 million episodes of treatment initiation. And once we went through the propensity matching, which is essentially a statistical technique to try to make sure that we compare apples to apples instead of apples to oranges, because, of course, prescription of certain medicines is not a random event in clinical practice, so we want to make sure that we compare patients that are like one another in every way that we can measure, except which medications they received. Once we went through that process, we ended up with about 235,000 episodes of SGLT-2 initiation, and the same number with other glucose-lowering drugs. And then we essentially examined outcomes across those 2 treatment groups. And we know the propensity match worked very nicely because the baseline characteristics of the patients were quite comparable. Actually, about 26 to 27% of patients had established cardiovascular disease, which is very close to what you normally see in the broad population of patients with type 2 diabetes in clinical practice. What we found actually is, from the standpoint of all-cause mortality and hospitalization for heart failure, was very consistent with what we found in CVD-REAL-1. There was a significantly lower risk for all-cause mortality, hospitalization for heart failure, and a composite of those 2 outcomes. And the data looked quite similar to what the findings of CVD-REAL-1 in, again, very different countries, very different patient populations, but very consistent findings from that standpoint of all-cause death and hospitalization for heart failure. Now, kind of pivoting more towards atrothrombotic outcomes, which is myocardial function and stroke, which were not examined in CVD-REAL-1, we actually found a lower risk of myocardial infarction. The reduction in that risk of myocardial infarction with SGLT-2 inhibitors versus other drugs was modest, but it was statistically significant. And we also reassuringly found lower risk of stroke. Now, I will point out in particular when it comes to stroke, because we had so many patients, and we had so many patients specifically from Asia-Pacific region, we had a very large number of stroke events, actually close to 6,500 strokes. And it's certainly separates studies like CVD-REAL-2 from almost anything else that we've seen in the literature about SGLT-2 inhibitors, because not only the number of patients was really high, but the number of events was extremely high as well. And of course, that helps when you're trying to look at association between different medications and their associations with patient outcomes. It was the same was true, by the way, for other outcomes. You know, we had over 2,000 myocardial infarctions. We had close to 10,000 events when it came to a composite of heart failure or death. And so I think that's one of the clear advantages of a large study like this, where you have lots of patients. And we also had relatively longer follow-up duration as compared to CVD-REAL-1, so we were able to accumulate a lot of events. Well, I think from a clinical practice implication standpoint, again, there are a couple of take-home points, I would say. First is when it comes to the relationship between initiation of SGLT-2 inhibitors versus other agents, the data appears to be very consistent regardless of the world regions that we look at, and actually regardless of the countries that we look at, despite differences in patient characteristics, where patients come from as far as geographic region is concerned, despite background socioeconomic, demographic, and clinical characteristics, because we've done a lot of subgroup analysis, for example, where the results also look very consistent. It's very reassuring to know that across all of these very diverse characteristics, the associations of SGLT-2 inhibitors with better cardiovascular outcomes is quite consistent. And again, I think that data is very much complementary to what we saw in clinical trials, and should be quite reassuring to clinicians from standpoint of evaluating SGLT-2 inhibitors as a class. The second, in particular, is actually about the atrothrombotic events and outcomes of myocardial infarction and stroke. Again, you know, there was a modest but significantly lower risk of myocardial infarction in patients initiated on SGLT-2 inhibitors. I think that's reassuring, and in particular with stroke, because early on there were some potential concerns raised about stroke risk with these agents. That was initially observed in EMPEROR outcome trial, where there was a slight numerical imbalance in favor of placebo versus empagliflozin, but it was not statistically significant. That was not seen in the CANVAS trial, where the point estimate for stroke was actually in a favorable direction for canagliflozin versus placebo, but that was also not statistically significant. Our results are certainly reassuring from that standpoint, certainly indicating absolutely no evidence of a higher risk of stroke, and if anything, again, pointing in a favorable direction. And again, from a clinical standpoint, I think that's quite reassuring that we see no increase in risk and all outcomes going clearly in the positive, favorable direction for SGLT-2 inhibitors versus other drugs in every outcome. CVD-REAL program, including CVD-REAL-1 and 2, is a kind of a evolving, living clinical research program. So we are definitely planning to do additional analysis, including data from CVD-REAL-2 countries, looking at various treatment combinations and various outcomes. In addition to that, there will be further countries that will be included in a CVD-REAL consortium going forward. So I think CVD-REAL as a entity, as a kind of a consortium, will continue to get bigger and better, and I think we'll continue to learn a lot from it. So I really look forward to having additional data to share with our colleagues in future meetings.